Good morning and welcome to the third annual Pediatric Innovation Showcase brought to you by Stanford Children's Health and Stanford Medicine. I am Charlotte Stallworth, Vice President of Strategic Partnerships at Stanford Children's Health. I'm a co-founder of this event and so excited to co-host again. This year, Dr. James Wall and I have partnered with Natalie Pageler to bring you curated content on trending topics of today, including equity, privacy, and security in pediatric healthcare. Today, you will hear from thought leaders from across the country, including Chris Gibbons, our keynote speaker, and they will educate and inspire you. We are also featuring innovators from Stanford Medicine, and you will get to see and hear about the amazing inventions and work they're doing and viral videos that will be featured throughout the day. At Stanford Medicine, collaboration within our internal entities and with external partners are key to developing and delivering novel healthcare solutions to pediatric patients around the world. So we will end the showcase today by asking you to join us in networking sessions where we can continue the conversations started today in the showcase and hopefully create some new collaborations. So at this time, Dr. James Wall will join us, and I will see you a little later today. Hi, James.
Hi, Charlotte. Thank you so much. So in the past decade, Lucile Packard Children's Hospital and Stanford School of Medicine have identified an unfortunate but real inequity in the development of health technologies and medical devices for pediatric and maternal patients that we serve. As a pediatric surgeon, I see this daily using the majority of devices that I use off-label. And it's also seen in data from the FDA, where there has been a robust growth in health technologies and devices for adult populations and a virtual flatline of approvals for some of our most vulnerable pediatric and maternal patients. So we don't just talk about innovation here at Stanford, we're doing something about it. We have developed a comprehensive program in partnership with the Stanford Bayer Center for Biodesign. And that program seeks to fill the pipeline with innovation teams focused on pediatric and maternal unmet clinical needs. It provides resources to development through a generous grant from the FDA for our Pediatric Device Consortium, as well as matching funds from the Cottrell Foundation. Those resources include expert consultants in regulatory, intellectual property, reimbursement, and other areas that are necessary to translate great concepts from idea to bedside. Over the past 3 years, our Pediatric Device Consortium has aided 23 projects from idea to bedside. 44% of those have gone on to clinical use, touching over 15,000 patients. These projects have also met the translational challenge from the School of Medicine and from the university in creating real jobs and generating over $27 million in follow-on funding. So it's now my distinct pleasure to welcome Dean Miner. Dean Miner, as many of you know, is the leader of the School of Medicine. He's the Carl and Elizabeth Naumann chair. Under his leadership, Stanford has really gone to the forefront of the biomedical revolution of precision health, which is a fundamental shift to more proactive and personalized healthcare that empowers people to lead healthy lives. He recently published a book on this that's a must-read, Discovering Precision Health, which I think I see in the background. And with that, I will thank Dean Miner for his remarks and welcome him to our showcase.
Well, thank you very much, James. And I want to thank you and Charlotte for your passion, your dedication for bringing together this very informative and exciting symposium, and for all the work that you and Charlotte do every day to advance the forefront of innovation in pediatric and maternal health care. One of the keys to innovation is dedication and passion among those who are the innovators. And James, you and Charlotte demonstrate that so powerfully. The COVID-19 pandemic has, of course, jarred us in so many ways. I don't think there have been very few people prior to January, February of last year that would have predicted we could have ended up in this situation that we found ourselves in for the past 14 months. And of course, we're not done yet, although we're starting to see a glimpse of the light at the end of the tunnel. But one of the most powerful messages that's come out of this pandemic is it's underscored in our country and indeed around the world the inequities that exist in health and health care. I think all of us here at Stanford Medicine have a passion for addressing these inequities, certainly in the populations we serve, our patients, but also through our leadership, through our innovation, through the focus that we bring in so many areas enabled by technology, to be able to come up with the solutions that will make sure we do a better job of preventing and managing the next pandemic, and have one of the positive outcomes of this pandemic be more of a focus and impact on inequities in health and healthcare. Certainly one of the things, the silver linings from COVID has been the demonstration that telehealth, telemedicine can and does work. And we're so fortunate to have leaders like Natalie Pageler, who even before the pandemic were thinking creatively and in innovative ways about how to extend telehealth services in pediatric and maternal health care. And then during the pandemic, when we had to scale things up very quickly, they responded with dedication and alacrity. As a result, we, both the children's and our adult healthcare delivery systems, have been beacons of success in making the transition to telehealth and making sure that that transition, where it makes sense in terms of being able to provide the type of patient care we want to provide, making sure that that transition continues in the future. The future of telehealth is truly, I think, without limits. And as James was saying, the opportunity to integrate with a standard video visit a variety of other ways of measuring health and health care will transform the way we're able to serve our patients in the future. What we must make sure, however, is that the rollout and the adoption of telehealth addresses and rectifies inequities in the access to care, and that it does not amplify and extend those inequities. I think we have the ability to make sure that it does expand healthcare services and does so in an equitable way, but it's going to require forethought and focus to make sure that it doesn't become a technological innovation that's only accessed and utilized by a few people who have other sources also of accessing healthcare delivery. We know we have to be careful about that because the rollout of COVID-19 vaccines in the United States demonstrates the dilemma. The phase 3 trials for these vaccines were among the most equitable and inclusive clinical trials ever conducted. The FDA and industry set up the inclusion criteria from the get-go in a way that ensured groups that were overrepresented in terms of numbers of cases also had access to enrollment in the phase 3 trials. And as a result, these phase 3 trials were demographically and socioeconomically balanced and diverse. However, we can't say the same thing about the rollout of the vaccine. There, because there was a last mile problem, we saw that the inequities in access, which have been prevalent in our healthcare delivery system, were also clearly evident in the rollout of vaccines. That's starting to get corrected now as we have more and more doses of vaccine available. And in our own region, thanks to the leadership of our healthcare delivery systems, Paul King and David Entwistle, we've done a number of things to reach out and offer vaccination to underserved communities, such as exist in San Jose and many other areas within our region. I know today's conference is going to be informative and exciting. Thank you all for participating. Thank you again to Charlotte and James for organizing the conference and for the work you do every day to advance the forefront of technology and improving health and healthcare for children and expectant mothers. Now, I'll turn it over to Natalie Pageler, or back to you, James, and then to Natalie. Thank you.
Thanks, Dean Miner. We'll pass it over to Natalie for the introduction. Thank you so much.
Thank you so much, Dean Miner. And thank you for your leadership and your support throughout the last year. It's been an incredible ride. So hi, everybody. I'm Natalie Pageler. I am a pediatric critical care physician and the Chief Medical Information Officer at Stanford Children's Health. Through my CMIO role, I get to work with incredibly talented folks in our Information Services Department, including our transformational Chief Technology Officer, Anshul Pandey, who was instrumental in helping us navigate the many technology needs over the last year and has helped plan this event as well. I also oversee our clinical informatics program and co-lead our digital health program at Stanford Children's Health. And I have the opportunity to serve as the program director for a phenomenal group of bright, energetic, and intrepid fellows in our clinical informatics fellowship program across Stanford Medicine. As you all have heard multiple times, we know the last year has been hard, but the COVID-19 pandemic has catalyzed a dramatic shift in the way we practice medicine. We've seen explosive growth in telehealth volumes across multiple different practice settings. We have also seen the deployment of creative new tools such as mobile apps and remote patient monitoring that help us take healthcare services to people wherever and whenever they need them. Unrelated to the pandemic, but coincidental in timing, we also saw the release of the 21st Century Cures Act final rule over the last year. This was the culmination of sweeping legislation and a national movement towards empowering patients with their own health data and towards facilitating improved interoperability so that we can achieve better health outcomes. Both of these major transitions will have significant durable impact on the delivery of healthcare in our country, helping us meet patients and families where they are and allowing us to provide more continuous, supportive, and proactive healthcare. However, as you've heard multiple times this morning, if we are not thoughtful and careful in how we design our evolving interventions and services, we risk leaving our most vulnerable populations behind and exacerbating disparities. Those particularly at risk include young children and their guardians, adolescents who are establishing health habits that will affect their entire lives, and the many diverse people on the other side of the digital divide. Today, you are going to hear from a wide range of experts who are thinking critically about how to address the unique needs and considerations of these populations and ensure that we include people of all ages and backgrounds in this healthcare revolution. I'm excited to introduce our keynote speaker, Dr. Chris Gibbons, to get us started thinking about the potential for reimagining healthcare through innovation.
Thank you very much, Natalie, for having me today. It's a pleasure to be with you. Let me first apologize for the background. As you might imagine, we're having a few technical issues, and so we're putting things together. In case you're wondering, that's my wife and I after we just finished a 25-mile cycle ride a few weeks ago. So apologize for that. Before we get started, I just wanted to say my talk today really represents kind of a synthesis of the work that we have been doing over the last more than 20 years now as a faculty member at Johns Hopkins, and also now with a lot of the newer work that I'm doing, the innovation and consulting work I'm doing with clients like the FCC, large multinational tech firms, federally qualified health centers, and physician practices. And while I won't explicitly call out any of those clients per se, the perspectives that you'll hear today will be from the work that we've done both in research and clinical practice and other places. And I'm also going to talk about a side of this that you probably have not thought about as much. I hope you find it valuable. So before we move to the next slide, as you know, much has been said about innovation. And many people are are talking about this term disruptive innovation. And one thing I've learned over, like I say, more than 20 years of doing this and walking in clinical communities and technological communities and poor underserved communities and policy communities, is that many times we're all using the same terms, but we're meaning different things and we don't even realize it. So to help ensure that for this talk, we're all on the same page, I wanted to go back a little and define a few terms. So next slide, please. So if we go back to 1997 and the work of Clayton Christensen, some of you may know him. He's a Harvard Business School professor who recently passed away. But his work had been to understand why businesses do well, what it takes, and what's going on. And he's the one that's credited with coining the term disruptive innovation. And it's based on 10 years worth of work that he put together in first a paper published in Harvard Business Review, but then published in this book in 1997 that he called The Innovator's Dilemma, Why New Technologies Cause Great Firms to Fail. And it's actually considered one of the top 5 business books ever written. So if you haven't read it, I would highly recommend that you read it. It's very informative, even for clinical practitioners and a health system. But the bottom line is he, in this book and in this work, describes 2 types of innovation, 2 basic types of innovation. The first type of innovation, you can click the next, click again. Is what he calls sustaining innovation. And sustaining innovation is that kind of innovation that improves sometimes significantly what we're doing. And this can be incredibly important for companies to stay ahead of the curve, stay ahead of the competition. It can result in a significant increase in revenues. And so it's an important kind. But he defined another time, you could click again, and this is what he calls disruptive innovation. Click again, please. And I'll just go ahead. So he defines disruptive innovation as something very different than sustaining innovation. Disruptive innovation is something that generally starts off small and the impact is so far-reaching that it simply can't even be predicted at the time the innovation is put in place. And the impact goes far beyond where it was originally intended to do. So many people talking about disruptive innovation, by definition, it's not, because you already see where it's going. A number of things, he said it's also not usually the shiny thing that we talk about, but the thing that's most disruptive is not what we do, but the fact that this innovation actually changes revenue models. So if you have an innovation that is based on the same revenue models you had before, it's likely not disruptive. It might be sustaining, it might be valuable, but it's not disruptive. And finally, the last point about disruptive innovation, it's not about cannibalizing and getting more out of the markets you already serve, or the patients you already serve, or the consumers you already serve. There's only so much you can get out of them. But it's actually this disruptive innovation enables you to capture entirely new markets that you were not able to capture before. And so it actually layers on top of the markets that you already have. And that's why disruptive innovation can be so exponential for the growth and revenue of those organizations who are able to achieve it. Next slide, please. So going back, we see that some of you may know who this is. This is Mark Andreasen, and that's both him on in his younger days on the cover of Time magazine, and then him later a few years ago. But he was credited in a Wall Street Journal article that he published in 2011 that he said famously, every company needs to become a software company. And that he anticipated, this young man on the left-hand side, that over the next 10 years, many more industries will be disrupted by software. And he has nothing to do with healthcare. So, today that doesn't sound like all too much, but back in 2011, most people would have said that we're already living in a fully technological era. The internet was everywhere. Amazon was 10 years old. The iPhone was about 4 years old. The App Store was generating $2.5 billion of revenue every quarter. Facebook had almost 1 billion users, about 900 million users, and Netflix was streaming about 2 billion hours of content every quarter. But Mr. Andreasen was predicting that the digital revolution was just beginning. And what he understood is that software and technology was not just about enabling us to do things better and faster, but allow us to do things that were never possible before. And he anticipated, rightly so, that this would change what was happening not only in the software and the tech sector, but in many other sectors in a way that most people were not prescient. And here we are, 10 years later, and it's beginning to happen in healthcare as he certainly predicted. Next slide, please. Okay, so why is the healthcare system changing? So from our perspective, when you think about it like this and you think about these kinds of things, it's about far more than just costs are too high and quality is variable and if waste, fraud, and inefficiency is there. Those are all true. But the main reason, you could click again, is that the world around us is changing in very profound ways. And those changes are coming into healthcare. And I'll try to illustrate that quickly for you today. Next slide, please. So what are some of the ways in which healthcare is changing, or which ways society is changing that are relevant to healthcare? Well, as you can see there, broadband and 5G. I won't talk about it today, but the bottom line, many people are confused about what that really is. This is the infrastructure that's going to enable everything in the future that we talk about being possible to happen. And the biggest innovation, or the biggest advancement over 5th generation wireless broadband from 4th generation, which is generally out there now, is that it'll enable much higher data transmission speeds, much lower latency, which is critical when you're talking about surgery and various other things. And then it will allow a much, much larger number of devices to connect to the network, what they call network density. And why this is so important is, quite frankly, because of some of the technical problems we're having today. When there's too many, with the 4G networks that we have now, sometimes you have too many people using the system too heavily at the same time, and it causes the whole system to not work well for any people. And we have to use these workarounds. And that's exactly what's happening now. But in a 5G environment, that's not likely to happen. Health apps, won't go into that, but now there's over 5 million apps available just in the Apple and the Google store. There's about 318,000 help apps, 200 new health apps being added every single day. And the question is, are people using them? Well, they have been downloaded more than 3 billion times. Health and fitness apps are the 9th most commonly downloaded app in the Apple App Store and represent about 3.5% of all apps downloaded, period. About 20% of millennials open more than 50 apps a day, or open their apps more than 50 times a day. The average adult opens an app more than 11 times per day. So apps are a new part of our existence. We have there, you can see AI and ML. You can go on to the, AI or ML. I won't go into that. There's good understanding of that there with this audience. We also have robots, but it's not only robotic surgery, which I'm sure you guys are just as familiar with, but it's also things like socially assistive and socially intelligent robots, which you may not have heard that much about, but these are robots that can work anywhere in the home, other places, to assist patients and assist people in doing both intelligent activities or mechanical type activities. It's also software robots, or bots as they're sometimes called, chat bots and conversational agents. We're becoming familiar with those, and also robotic process automation, which is a whole nother set of things that I won't talk about today. But these All of these things fit under the topic of robots and have their implications not only on the greater world, but will have tremendous implications in the healthcare sector and in the healthcare world. Virtual, augmented, and extended reality, again, we won't talk deeply about that. And the Internet of Things, I don't need to explain. Next slide, please. So the real reality that we have here is that the drivers of healthcare disruption, true disruption, not just sustaining innovation, the drivers to disrupt the disruptive forces are both internal and external to the healthcare sector. And the ones that are external, the healthcare sector has little control over. And the pace of technological and software advances are now, quite honestly, outstripping the ability of providers and healthcare systems to keep up with them, and patients are starting to demand this because they're getting it from other sectors. And the convenience, the prices that they're paying, they want that in their healthcare too. So it's not really just that docs want to innovate, and our research is taking us that way. Patients, if we don't provide what they're looking for, they go other places to get it, and that's where big tech companies and Teladoc and other companies, not because of COVID, long before COVID, saw an opportunity and did quite well and continue to do quite well because they saw patients wanting something that traditional healthcare simply wasn't providing. But now we're coming around to it, which is great. And these external factors, though, are invalidating historic norms and changing even clinical practice, what we do. And I'll illustrate that a little bit today. Next slide, please. So when we talk about in healthcare, for most people in the healthcare space, when we're talking about healthcare disruption or healthcare innovation, 95 to 99% of the time, you can click again, we're talking about one thing, the practice of medicine, clinical practice. And that's incredibly important, absolutely important. And it's good that we focus on that. We're the ones that should focus on that. But in the work that we've done over the last several decades, we find that there's probably at least 3 more areas in healthcare where innovation and disruptive innovation can have an impact and are likely to have an impact beyond what the doctor and the nurses do, even if you don't change that at all. And those 3 areas, click again, please. The one is the organization and delivery of care aside from what a doctor and nurse does. And now it's easier for people to see that because of COVID, right? We didn't change the way we diagnose things substantially in the last 18 months. We did substantially change the way and where healthcare is being delivered and how it's being delivered. And so that's what, but that it's the end of it isn't telehealth and remote patient monitoring. That's only the very tip of the beginning of the iceberg, and we'll try to illustrate that for you. Click again, please. The next thing is the patient experience. Again, COVID makes this a little easier to understand. Give a patient a choice of having to come to a doctor's office, a clinic, or a health system, or stay at home and get the same care. They're going to stay at home at every time. And it's a much better experience for them. And what we're finding in the broader world, because of technology, the customer experience, in this case, patient experience, is becoming something that is so dominant, it's driving consumers' perception of value. So those things that are more convenient are considered more valuable often than those things that are less convenient, but might even be higher quality. And so what I'm illustrating for you is the principles on which we used to compete as businesses are changing right before our eyes. And that's what technology does. Click one more time. And then the last area is healthcare revenue models as predicted, as laid out by Clayton Christensen many years ago. Those are changing right before my eyes. And I'm not talking about bundled payment systems, pay for performance and all that. I'm talking far beyond that. And maybe we'll have some time to talk about that later if you're interested. Next slide, please. So let's see what's happening within the healthcare system. And maybe you have taken note of these things, maybe you haven't. But in June of a few years ago, 2016, perhaps you saw in this this little medical journal here that I'm sure some of you have heard. Click again, please. An article came out and it says, do we still even need hospitals? In the British Medical Journal. And the point of the article was, if observation takes place in the community with specialists that can be accessed digitally and remotely, doesn't the hospital become more like a university campus where students rarely, if ever, really need to go into the classroom itself? That's what BMJ was publishing. Next slide, please. Here's another little journal you may have heard of, New England Journal. They came out in the next year with an article that says, do hospitals even make sense? New England Journal, we're not talking about some ragtag outfit here. Click one more time, please. And the bottom line of this article was that inpatient care is not what the typical consumer needs. Yet our current healthcare system is framed entirely around hospitals and hospital systems. Next slide, please. This august medical journal, the New York Times, you may have heard of it, the next year came out with an article that said, are hospitals becoming obsolete? Next click, please. Next click. Yeah, and the bottom line of this article is, while they may never go away completely, they will continue to shrink in number and importance, and that is inevitable and good. Next slide, please. A few things happened on September 24, 2019. Remember that date. September 24. One of the things in Becker's Hospital Review, Walmart announced that it plans to unveil to build a healthcare workforce, not a healthcare sales workforce, a healthcare workforce. Walmart. Click again. What do they exactly mean by that? They are now offering 7 bachelor's degrees and 2 career diplomas in health-related fields. Walmart is doing this. Click again, please. But that's not the kicker. You can get a degree for $1 a day. You can get a full bachelor's degree that will outfit you to work in healthcare-oriented positions for the equivalent of $365 a year. And why are they doing this? Click one more time, please. Why are they doing this? To fill future healthcare jobs, not health sales jobs, healthcare jobs across Walmart and Sam's. We can say, oh, they don't know what they're doing, they're going to fail, and they might, but they might not. And they're already working on this pretty avidly. Next slide, please. September 24, 2019, again, Forbes this time comes out with an article that says, healthcare may eventually become a bigger business for Best Buy than selling electronics, not selling digital devices. Healthcare may become a bigger business for Best Buy than selling electronics. Click again, please. How big? This is Forbes based on a Wall Street study that health monitoring services, not health monitoring devices, selling them, health monitoring services for seniors and other digital health initiatives could generate anywhere between $11 and $46 billion for Best Buy. Those are the working assumptions based on research that they are working under right now. Next slide, please. Kansas City Business Journal, Humana, Walgreens expand their pilot of senior care centers. This is kind of old hat to us now. Click again. They're opening primary care clinics, a version of retail healthcare. And click again. They're opening 7 full service primary care clinics, not just come in and get your eyes looked at, full service primary care clinics, 3 of which are inside a Walgreens. Why? Because it's more convenient for patients. They get in faster, prices are clear, and patient satisfaction is through the roof. They like it. It's going well. Next slide, please. New York Times, Aetna CVS merger, it's old news now, we know about it, but CVS recently added on that same day, September 24, 2019, all of these things happened on that day. They announced that they are adding this first digital health app to its offering. Click again, please. What is it? It's Sleepio. It's an all digital insomnia treatment app. Click again, please. It's an animated, it's an avatar therapist that's basically giving CBT to patients. No human involved at all, based on AI and other things. And the reason they're doing it is because, click again, it's based on several rigorous studies that show its efficacy. And the kicker, you don't need a prescription for it. If you think you want it and you ask for it, you get it. Download the app and you can use it right now, available. Click again, please. Again, chosen because of the studies that show that it actually works. Next slide, please. Amazon, we all know what they're doing, but 2 years ago, about this same time, almost 2 years ago, September 24, 2019, Amazon actually announced the Amazon Care program as a fully virtual medical clinic, a fully virtual medical clinic. Click again, please. The concept here is that there is no brick and mortar involved at all. Click again, please. You initiate a consultation with a healthcare provider by a mobile app, by text messaging, or online. And when you do, a nurse will get back with you within 60 seconds. They advertise most of the time, within 60 seconds. How often does that happen at your health center? Doesn't happen too often at my health center either. Click again, please. But not only that, click again. If you need to actually, they handle everything online, but if you actually need to see somebody, they don't send you to a hospital or a clinic. The nurse comes to your home. The nurse comes to your home. And click one more time, please. And so if you need meds, guess what? They own a pharma company. They'll prescribe them for you. And if you have an Amazon Prime account and live in an area with an Amazon Go is available, those meds will be delivered to your house by drone within 1 hour of their prescribing. This is the future, and the future is happening now. Next slide, please. CNN, we all know about the Apple Watch, and although there was some early criticisms of it in the healthcare sector, again, the studies are showing something quite opposite. Click one more time, please. We now have the results of a very large study. You guys probably know about it. A randomized controlled trial, over 400,000 patients. How many trials do you know that big? Click again, please. You had to download the study app to your watch to participate in the trial. One of the things you had to do, click again, please. And the bottom line has its ability to detect AFib has high positive predictive value and with few false positives. And people say, well, it might tell them stuff, but patients aren't going to do anything about it. Click again, please. Well, the evidence said that 76% of the participants did actually follow up and get appropriate care from that Apple Watch. Click one more time, please. And no clinic or hospital was involved at all. The study actually did have an arm where you could go to the hospital, where some of the patients did go to the hospital to verify if what the Apple Watch was saying was true. And in fact, it was. Next slide, please. So what's the emerging reality? Click again, please, here. What we see is September 24th, at least in our estimation, 2019 is probably the single most consequential day in healthcare with regards to digital health. And most people in the healthcare system didn't even take note. Click again, please. Healthcare is rapidly changing now. It's not going to change. It is changing, and it's changing more than just involving clinical practice and what doctors do and the tools they use to do it. Click again, please. And these changes, many of them, are not coming from the healthcare sector. You, like I view that partly as problematic. I think we in the healthcare center need to be more there, but the problem is we are missing the bucket. We are totally missing these broader societal changes that patients and consumers want, and so we're not providing the tools, which represents an opening for big tech to do it, because they do keep close tabs on their consumers and try to give them what they want in order to sell them what they want to sell them. And so that's why it's happening that way. Click again. And the bottom line, in all of the things that I've shared with you just now, the hospital is no longer considered central to the visions of healthcare delivery. And that's the future that is here. Will it all fail? No. Will it all succeed? Probably not. But this direction is the direction the world is going, like it or not. Next slide, please. So this is what most of you obviously think, and much of the healthcare sector takes in terms for telehealth. I don't need to explain this to you. Next slide, please. But here are these things, and when I used to give this talk, I'd have to explain half of these things, but you know them already. Amazon Alexa, the Apple Watch there with the EKG. We got in the center, that's actually a Band-Aid with electronic circuitry in it so that it can monitor several things and send that information wirelessly wherever the owner would like it to go. That's a house down there, representative of a smart house, and a Tesla, not because it's a Tesla, but representative of a smart car. Next slide. Upper left there, you have what's supposed to represent a pill with a chip in it. You all probably know these are starting to be available. And so once you take a medication, it can inform about medication adherence, bioavailability, all kinds of things and that information can be sent wherever. That's a Google Home there on the top right. You may recognize that's new colonoscopy, a pill with a camera in it. You swallow it. As it's transmitting through your GI tract, it's taking pictures and sending those pictures back to the doctor, and then you pass it in your stool a couple days later. They're already in use in this part of the country. I assume they're in use in your part of the country as well. Down on the bottom left, that's a Fitbit tracing, and this particular Fitbit tracing of the heart actually helped diagnose a cardiac condition and save a person's life. And this was noted a few years ago. The idea here being that many clinicians thought that these technological health tools that did not connect directly to the health system have no value in health. And I think that's been pretty well shown not to be true. The picture in the middle, there is actually a robot. And if I could show you the video, you would see that this would be a very life-like robot. She has skin that's very much like human skin, a voice, facial expressions. And the point is, robots are no longer those lost in space Star Trek things that we talked about. They are very, very human in many respects. And the last one there, that's a tattoo. Again, with microcircuitry embedded in it, can do some of the many same things. Next slide, please. So what do all these things have in common? Click again, please. None of them are limited to use in a hospital, not any of them. Click again, please. And they're all rely on broadband networks and digital devices to transfer data, but also to deliver health services of one form or another. Click again, please. And in fact, they really are all emerging forms of telehealth and digital health. Click again. Next slide, please. So what is beginning to emerge is a construct where we can think of a digital health ecosystem that includes clinical practice delivered and clinical care delivered digitally and virtually. Click again, please. But it also could include public health services, surveillance of various kinds, but it also could include social services and wellness services and decision support and cognitive performance services, not only for providers, but also for patients and their caregivers, which are now crying out for these things and have been doing so for a long time, but it's just not an area the healthcare system has done well in responding to in the past. So the future digital care ecosystem, clinical care is a critical part of it, but it's only one part of it. There are these other parts that will become part of it because patients rely on more than just their doctors and nurses for their health. Now, we in the healthcare system should be leading in all of these areas and overseeing all of this, but currently we're not. And I'm arguing that if we continue to have the rather narrow view, I understand why we have done it because of how healthcare has grown, what will happen is a healthcare system in which we are one critical part, but somebody else controls healthcare in the future. Next slide, please. So we can take this just a couple steps further. Talking about, you've heard the term smart technology and how everybody talks about their new solution in healthcare being smart. And in the early years, click again, please, just a few years ago, maybe 5, 6, 7 years ago, we were talking about remote sensing with alerts to a provider, an EMR, or a patient. Click again, please. But then we learned about alert fatigue and false positives and natural variability among patients, and atypical presentations that these the sensing was nice. We can tell your blood pressure at home, but it doesn't tell us why your blood pressure is high, or it doesn't tell us why, and so the Apple Watch is a little bit of an improvement on that. Next slide, please. But today, smart technology has evolved to be something very, very, very different, truly smart technology. Click again, please. Smart technology, and again, this is not necessarily in health. This is smart technology in any realm. It are really devices that have embedded computer chips in them. So the horsepower is in the device itself. It's not in the remote server somewhere, that can actually detect like a sensor, but also understand and determine the best reaction or the best action to address whatever it's detecting. And then it can also automatically, it doesn't need to send information to a provider and then get a command from a provider. It can automatically respond appropriately without any human intervention. We already have some of these on the market, as you probably know, in healthcare. The continuous glucose monitor is one such device, monitors your glucose any number of times during the day, determines the amount of insulin you need, and then automatically doses you multiple times a day. I'm suggesting that there will be many, many, many more of these kinds of devices and solutions. One, because patients love them, it gives them a lot more flexibility. And many of the docs who use them also love them because it frees them up from having to spend time titrating insulin and worrying about that. And they can practice at the top of their license. Next slide, please. But there's one more step. You can go another step. So now we have, technologies that we're talking about that are not just sort of enablers, but they're smart. They can detect things, understand things, and be responsive to things in critical ways that have clinical meaning and clinical impact, as well as social impact and other kinds of impact. But now you can think about it, and they're not limited to a geographic place, a hospital, a clinic, a doctor's office. They can be used anywhere, almost anytime, in the home or anywhere else. But we can take this even a step further. Next slide, please. So something that you may think has nothing to do with this idea of smart cities and smart communities. We began looking at this several years ago, and we noted, click again, please, that smart cities basically are defined as using technology, data, AI, and broadband in real time to improve the living for its residents. But guess what? That same infrastructure, technology, data, AI, and broadband, that's the same infrastructure that we need to deliver all the services that we were just talking about and to deliver healthcare. So we began to think, it was like, wait a minute, if we got the same infrastructure, is there some innovation in healthcare that can tie into this, that allow healthcare to go some places and do some things that it couldn't do, but ride on the infrastructure that is across a whole smart city? And not to forget underserved populations. If you take this model, then the broadband networks, the infrastructure needs to be available to everyone in the city, not just the folks living in Uptown, not just the rich folk, but to everybody. And if you do that, then you've solved the hardest problem, because the hardest problem is often getting the broadband to those who need it. But once you've solved that, then it's infinitely easier to figure out how, not easy, but infinitely easier to figure out how to get people online to receive the digital services that can benefit them. So next slide, please. So, and because we're moving into 5G, we're now really, in a realistic kind of way, beginning to move into an age where it's ubiquitous computing. In other words, you can be computing, you can be connected to the cloud, to the broadband, to the internet, anywhere you are, not just at a hospital, not just in your home, but in your car, walking down the street, on the beach, in the park, anywhere, anytime. Well, if that's true, and the infrastructure is there to make it happen, then we ought to be able to deliver digital services anywhere you are, not just in the hospital or even not just in your home, in your car, on the street, on the park bench, at the beach, anywhere, anytime. And in fact, many other industries have already begun to think this way. And that's why automakers are already putting, not just thinking about it, putting digital health functionality into their cars. Right now, on the market, Jaguar has health functionalities built into its car, built into the car. I can't talk about it, running out of time, but we'll just go on. Next slide, please. Come back to it if we have some time. So the final piece is then you can really define a concept of smart care. Now, people have used that term a lot. It's really a marketing term most of the time. But what we have done is said, let's be a little more specific. And we've defined it as not a marketing term. Click again, please. But really, if you think about smart technologies, as we just talked about them, in being used then in the context of health or digital health across a place like a smart city, then it enables you to go some other places. Click again, please. It enables you to really use the same infrastructure, technology, data, AI, and broadband to deliver automated health services, not only in-person ones, but automated health services anytime, on demand, not only when the doctor's office is open or the clinic is open, but when the patient needs it, when they ask for it, anywhere the person is located in the community at any time. Same infrastructure for what we're using to do now, but deployed at scale, which is where we're going, can enable disruption. Next slide, please. Use the asthma home. So to give you a quick example, I know we're running out of time. This is some work we did for the FCC, because one of the things they asked us to do, well, tell us what could the future be? What could broadband enable? And so we developed a number of essentially future case scenarios. One is, imagine you're living in this type of city now where all of this stuff is available and the sensors are not on your watch that you wear or on the clothing that you wear, but they're built into the homes, into the walls, into the roofs, into the ceilings, into the lights, into the park benches. They're everywhere. They built into the environments around us. You don't have to turn them on to use them. They work when they detect when they need to work, and they automatically work. So you're living in that world that I'm describing now, and you're living in that kind of home. You have a son or daughter that has asthma. And she's 5, 6 years old. And I don't have to explain that to you when I talk to other audiences, I do, but you tuck her into bed and you wonder, you go back downstairs to do whatever it is you're going to do. Is tonight going to be the night? Is she going to have an asthma attack in the middle of the night? Am I going to hear it so that I can run in there and help her, get her nebulizing treatment or her meter-dose inhaler with the spacer appropriately? Well, tonight is, in fact, the night. She does have that attack in the middle of the night, but because she lives in this home, within a fraction of a second, the sensors in the home detect that she's having increased work of breathing. It sends that information to the cloud. It analyzes it in conjunction with her EMR, her history, her everything else that's going on. It recognizes she's about to have an impending asthma attack and sends 2 commands, not to the doctor, not to you, the parent, but back to the house, and specifically to the room in which she is living. It says 2 things: raise the humidity in that room, and 2, out of the vents where the heat comes, give 2 puffs of albuterol. I don't have to explain to you what that means. In other audiences, I do. And there you have, before she wakes up, before anybody knows what's happening, she's received healthcare and aborted that asthma attack. And you don't know anything about it till the next day you check your email or your phone and you see what happened. That's what's possible in healthcare of the future. Next slide, please. So I don't have time to go through all of this. This is some work we did and published in a journal that Kevin Schulman, who's out there with you guys, used to head up. But we anticipate that because of these kind of changes, these extra healthcare changes, healthcare sector changes, as well as the internal changes, the demise of hospitals that we're already seeing, hospitals starting to close. It's not just a rural phenomenon, but for all these pressures that we're suggesting that in the future, healthcare in hospitals will probably be only about 5 to 10% of the care that's delivered. The next fraction will be some variation of the hospital at home model. I didn't talk about it, but you guys, I think, are familiar with it. But if you can think about one home set up that way to provide hospital level care in a home, what if communities were purpose built in order to do that? Or communities retrofitted, so every home in that community was outfitted to do that. You could think about smart care then communities, or maybe this is the new ACO, something like that. But the biggest fraction of care, you can see there 40 to 50%, is this category that we're calling smart care, which is really a brand new category, which entails a number of things. But it really is to say technology is not only changing how care is organized and delivered, but it's changing what is considered care, what is considered healthcare services, and who's delivering it, whether it's a person or a piece of technology or both, an algorithm. But it includes retail healthcare, it includes healthcare, not a marketing term, but services delivered through mobile devices, as well as virtual care. And then if all this is happening, you could envision the place where, in the same way as we got 10,000 airplanes, or we used to have 10,000 airplanes in the sky, you need air traffic controllers to get it all straight and keep it all straight from bumping into each other. You could envision, and we published this in 2017. You can go get the article right now. We envision the need for essentially data traffic controllers, essentially the same kind of thing, and that might be one iteration out there. Lo and behold, Mercy Medical System has built the first one, a new hospital, 4 or 5 stories high, filled with doctors, nurses, and technology, not one clinical bed in it. Not one clinical bed in it. It's all monitoring the care that they are delivering to patients located in other places. Some of it is their own clinics, but also patients all over the country, all over the world. Significant revenue models are coming out of it. And I understand Regan Street Institute, affiliated with the Indiana University, is building the second one right now. Hospital, virtual care centers, a hospital without one single bed in it. Next slide, please. So what does this mean for patients? Real quick, click again, please. Well, you can actually keep clicking. There's a whole bunch of things here. You don't have to, the ones that are in yellow are things that are already have happened and the white ones haven't, but things like insurance companies will become health companies. We're already seeing that happen. Retail stores, pharmacies, and post offices become health centers. Your TV and any other screen will become your doctor's office. Your smartphone will become a health device. Consumer technologies, clothes, and apps will assist with health management, and patients will support each other through social media. All of those things are beginning to happen, but here are a few things that aren't. Doctors will treat environments, not just patients. Our medicines will tell us when they need to be taken. The car will become your ambulance if it detects it needs to be an ambulance. No population will be hard to reach because we'll be able to reach them all through the technology. Even underserved populations, a very high percentage of them have technology. It may not always be on, it's intermittently, but very high percentages, not 100%, but very high percentages of them have technology. Healthcare becomes embedded in everyday life rather than being something we go someplace to get. And finally, your home will become your hospital, if that's what it needs to be. Next slide, please. And so we think there are tremendous implications for health disparities here. Don't have time to talk about any of them, but tremendous. Next slide. The only thing I will say about this is that there's the question, ask yourself, click again, please. Basically, how else are we going to contact everyone, including underserved populations? How are we going to connect with everyone, including underserved populations in America, and connect them to the people, information, or other resources they need to become healthy or stay well without greater reliance on technology and broadband networks on which they operate? How are we going to do that? If I was there with you in audience, I'd stop and listen to hear comments from you. I've done it 100 times to 100 audiences, and I always get the same answer. There is no answer, because the answer is obvious. The only way we're going to do it is by relying more on these technologies beyond clinical settings and beyond the ways that we're doing it than we're doing it now. And if we don't do that, we will continue to have the problems that we continue to have. Next slide, please. So let me close by saying, so what's left for hospitals? In some words, you might say I've painted a pretty rough picture for the future of hospitals. Click again, please. Well, I actually think that's the wrong question. I think that's not the right question to ask. Next slide, please. The real question is, what must hospitals become? Because I think I've made a cogent case to you today that for the overwhelming majority of hospitals, not all, but most hospitals, if they remain what they used to be, they're likely not to survive, or they're not likely to survive without a huge amount of red ink. So what must they become in order to survive? Click again, please. Some will be able to say largely the same. This will probably be some of the larger institutions, but I don't think we'll need all. Yes, keep clicking. We'll need all of them. Some of them will need to become virtual hospitals, like Mercy has already started to do in their system. Others may, these are some, again, some work that we've done, said a hospital might take on the role of being more like an Amazon fulfillment center. It's not where you go to get things done, but it is the place that enables things to happen in your home. If you need X, Y, and Z, or it provides the Wi-Fi to broadband, whatever it is, it becomes more of a fulfillment center than a site for care. But it enables care to happen wherever it needs to happen. And digital smart care delivery system, kind of a hybrid of all of those things. These are just some of the concepts that we have been discussing with clients and helping them move in that direction. But it's clear hospitals have to become something. And if most of them, and if they stay without innovating themselves and rely on what they've been doing, it's going to be a rough road. Next slide, please. So the last thing, can traditional revenue models survive? Bottom line, it'll be rough. It'll be very hard if you're relying on traditional revenues and sustaining innovation to carry you through this period of disruptive innovation. And technology has absolutely disrupted every sector in the way that I described that is likely to happen in healthcare. The same thing has happened in every other sector, and they've had to respond in that way. Healthcare just is the last one. And so revenue models have changed in every other sector. So I can envision the day when health insurance is not the dominant player. That's another day. We can talk about it some other way. Next slide, please. So in closing, the real world, what's the impact of this typical potential disruption? It goes in our mind far beyond telehealth and remote patient monitoring, even far beyond hospital at home model. It takes in retail healthcare, of which we're seeing many models. Not all of them work. You all know Haven. Haven was a big, high-profile one that failed. It didn't work. But now we have other ones. We have, CVS, Aetna CVS. We got Walgreens at the corner of Happy and Healthy. We've got Amazon Care. Some of them are going to work. But you can go beyond that into things that ambient assisted living, smart homes, smart care. You can even think about this on the level of smart cities, neighborhoods, and communities, and basically ecosystems that are digital ecosystems that can deliver health and care anytime, anywhere. Next slide, please. So it's a little foolhardy to think that won't happen in healthcare. And here I cite some examples of these on the right. Remember Woolworth and Woolco, Circuit City, AP. These used to be dominant organizations in their sectors. They all resisted what technology was doing to their sector. And they're not smaller now. They didn't lose market share. They're gone. They're gone. They are no longer companies. They're all defunct. Some of that's going to come to healthcare. It's a tough message, but I think there's no reason to believe that healthcare is somehow different when we are moving towards more of a market-based healthcare system, and therefore we're going to have to be responsive to these things. It will happen. People will still get sick, and need care, but how, when, where they get it is changing because of technology. Next slide. So innovation, the bottom line is innovation is easy. Change is already here. Transformation or disruption is coming quickly. We have the opportunity to create it on our own, those of us that are in the healthcare system. But if for any reason we do not, it will be hoisted upon us. Next slide. Thank you very much.
Thank you, Chris. We really appreciate that visionary oversight. So many lessons learned from your analysis of where we are today in healthcare and where we're going. I think this is just the perfect setup for the rest of the program, where we're going to really dig into the tactical issues around delivering components of this vision that you have in digital health, and how we're going to completely change how the healthcare system is in the future. So we really appreciate your time, giving us your vision. For participants in the webinar, what we're going to do now is go to a few videos, and we'll be back live with our first panel discussion in 5 minutes at 9:40. Again, Chris, thank you so much. And we'll see everyone at 9:40.